Hi everyone, I am Dr. Kaveshri. What are the nerves related to the mandible? What is typical cervical vertebrae and what are atypical cervical vertebrae? So let us study about the osteology of mandible and cervical vertebrae. So the mandible is otherwise called as the lower jaw. It is the largest and the strongest and the lowest and only movable bone of the skull, and it bears the lower teeth, hence it is called as the lower jaw. So we are seeing here the alveolar border. So along with the tooth sockets or the alveolar border is present. This is horseshoe shaped bone. So we can make out it is horseshoe shaped bone. It consists of three parts. So this much is the body. So in the center, the horizontal part is called as the body and the two rami are the vertical part. So from here to here, these are the two vertical rami on either sides. So these are vertically placed. Now body of the mandible represents two surfaces. So when we hold from the inner half, so this is the inner view what we are seeing. So this is the inner view. From the inner view, this will be the internal surface, and from exterior or outer surface. So this has got two surfaces, external surface and internal surface, and two borders, that is the superior border and the inferior border. The superior border is otherwise also called as the alveolar border or process. So this is the one where the tooth sockets are present, upper border. It bears the sockets of the lower 16 teeth. So we know that 2, 1, 2, 3. So this is the formula used for the tooth. So total 16 teeth will be there along the inferior border. Then the inferior border is also called as the base of the mandible. So this is called as the base of mandible, the body. Inferior border is called as base of the mandible, and it has got a smaller depression called as the digastric fossa. So on the depression along the inferior border, so this is called as the digastric fossa. On either sides near the median plane, so this is the median plane, on either sides of the median plane is the digastric fossa. So name itself is telling what is the attachment there. It is the anterior belly of digastric, attachment to the digastric fossa. The surface of the body of the mandible has got some features. So what is that? Symphysis menti. So we know that symphysis means these are the cartilaginous type of joints. So secondary cartilaginous type of joints in the median plane called as the symphysis. So it is in the chin, hence the name symphysis menti, which is called as the mental or the chin. Then mental protuberance is present. So this mental protuberance is an elevation or a protruded area along the lower border, and the inner aspect of the symphysis menti, that is the chin here, lower part, it consists of two tubercles, that is an upper and a lower genial tubercles. So it will have two tubercles, upper and lower genial tubercles, and this provides attachment to genioglossus above and geniohyoid below. So these two muscles are getting attached to the genial tubercles. Then it has got mental foramen. So mental foramen is present along the outer surface or the external surface. Then this is for the same name nerve, that is the mental nerve and the vessels, which are nothing but the mental nerve is a terminal branch of the mandibular nerve. Then we have the same name mental vessels through the foramen. Then there is an oblique line on the external surface here. This is the oblique line on the external surface, which is continuation from the anterior border of the ramus. It continues downwards as this oblique line. Then one more feature is the incisive fossa. So below the incisor teeth, so we know that there are central incisors and lateral incisors. So below the central incisors there is a depression which is called as the incisive fossa. Then mylohyoid line. So this is present along the inner surface. So we see here the mylohyoid line along the interior or the inner surface as a prominent oblique ridge. The mylohyoid groove also is present. So, below that a shallow depression. Then for the mylohyoid nerve and the vessels. So, mylohyoid line is there and below that there is a groove for the mylohyoid nerves and vessels. So, this is along the inner aspect or inner surface. Then along the inner aspect again there is a fossa which is called as sublingual fossa. So, this is for the sublingual gland. Then submandibular fossa. So, this is for the submandibular gland. So, which is that line? It is the mylohyoid line which divides this into two fossa. So, above and anteriorly it is sublingual fossa, below and posteriorly it is the submandibular fossa. Coming to the ramus of the mandible, it is quadrilateral in shape. So, this is the quadrilateral in shape, ramus of the mandible. So, it has got vertical, it is a vertical plate of the bone that projects upwards from the posterior part of the body. So, this much is the body. So, from here body upward projection. So, this is called as a ramus. Then it has got two surfaces. So, what are those? When we see like on the outer surface or otherwise called as the lateral surface. So, this is the lateral surface and the inner half or the inner surface here will be the medial surface. Then it has got four borders, as the name itself is telling, it is quadrilateral. So, it should have four borders. So, what are those borders? So, this is the anterior border, then this is the posterior border, then this is the superior border and here it is the inferior border. Then it has got two processes. So, what is that? So, it is the condylar process posteriorly and coronoid process anteriorly. So, this condyloid process is expanded on the upper half, so or the upper part, which is called as the head of the mandible. There is a constricted portion just below the head and that is called as the neck of the mandible. So, this is about the condyloid process what we are speaking. Then anteriorly the sharp projection or the pointing process. So, this is called as the coronoid process along the anterior part. Then angle of the mandible. So, this is the angle. So, it is formed between the posterior and inferior borders of the ramus of mandible. So, this is the posterior border and here this is the inferior border. So, this forms an angle called as the angle of mandible. The lateral surface of the ramus shows the oblique ridge for the masseter muscle attachment. So, we know that the muscles of mastication are getting attached or inserted into the mandible. So, the lateral surface of the ramus of the mandible has got several oblique ridges which is showing the attachment of the masseter muscle. Then we have the medial surface of the ramus. So, medial surface shows the mandibular foramen. Then it shows the linguella. So, tongue-like projection, spiny projection. Linguella means tongue-like projection. So, this is covering anterior to the mandibular foramen. We are seeing the linguella. Then there is a mylohyoid groove which we mentioned for the mylohyoid nerves and vessels, which is present below the mylohyoid line. Then so, this mandibular foramen is for the important structures and this would be the spotter question. So, inferior alveolar nerves and vessels passes through this mandibular foramen and the linguella is protecting or present anterior to this. Next, the ligaments attached to the mandible. So, if the question is asked, name the ligaments attached to the mandible. So, what are those? So, we have just below the head of the mandible or posterior part of the neck of the mandible, there is an attachment of lateral ligament of temporomandibular joint. So, this condyloid process will articulate with the mandibular fossa of the skull bone. So, this will be the mandibular fossa of the skull bone to form the TM joint. So, this is a condyloid type of synovial joint. So, to this joint the ligament which is related to is the lateral ligament of the temporomandibular joint along the posterior part of the neck of the mandible. Then along the angle of the mandible, so we know that this is the angle. So, along the angle of the mandible there is one more ligament called as the stylomandibular ligament. So, this stylomandibular ligament is attached from the styloid process of the temporal bone to the angle of the mandible, and this ligament it differentiates the parotid gland and the submandibular salivary gland. Then we have one more ligament. So, here on the inner half or the inner surface it is shown as sphenomandibular ligament. So, this sphenoid process of the temporal bone from there till the, so this is the linguala. So, till there to the linguala is the attachment of sphenomandibular ligament. The sphenomandibular ligament is a remnant of the or the derivative of the pharyngeal arch, that is the first pharyngeal arch, whereas the stylomandibular ligament is the thickening of the deep fascia or the cervical deep fascia. Then we have one more ligament called as the pterygomandibular ligament. So, from the pterygoid process of the sphenoid bone, so this is seen along the norma basalis of the skull. So, from the pterygoid process till the mandibular, the mandible, that is behind the third molar tooth along the inner surface. So, we have the attachment of pterygomandibular ligament. It is otherwise called as pterygomandibular raphe, which gives attachment to the buccinator muscle. The muscles of mastication are attached or inserted to the ramus of the mandible. So, the blue is showing the insertions. So, we can make out that along the lateral surface of the ramus it is the insertion of masseter muscle. Then we have the lateral pterygoid muscle. So, this is inserted. So, this is the second masticatory muscle. So, this is inserted into pterygoid fovea. So, this is a spotter question. So, it is called as the pterygoid fovea because it is giving insertion to the lateral pterygoid muscle. This is called as pterygoid fovea. Fovea means depression. So, just below the head of the mandible there is a depression for the lateral pterygoid muscle attachment. Then the next muscle of mastication, that is the temporalis muscle, it is getting inserted to the tip of the coronoid process as well as to the anterior border of the ramus of the mandible as well as partly to the outer surface of the ramus of the mandible. So, that is the temporalis muscle. Then we have one more muscle, that is the medial pterygoid muscle of mastication along the medial surface. So, this is the outer surface what we are seeing and this is the inner surface. So, along the inner surface posteromedial to the mandibular foramen. So, this is the mandibular foramen. Posteromedial to the mandibular foramen and along the angle of the mandible there is insertion of this medial pterygoid muscle. So, these are the 4 masticatory muscles. Then apart from that we also see that is the origin or the red color is the origin of the buccinator muscle. So, this is the muscle of the cheek. So, this is a facial muscle, that is the buccinator. We mentioned this that it gets origin along the alveolar border of the mandible. So, these are the lower fibers of the buccinator muscle along the third molar tooth, also from the pterygomandibular raphe. Then the other muscles of facial expression. So, this is the mental foramen. So, surrounding this mental foramen there is origin of these muscles of facial expression, that is depressor anguli oris, then depressor labii inferioris. So, labii means the lips and depression of the lower lips and along the inferior margin, hence called as depressor labii inferioris. Then one more muscle here, so this would be the mentalis, few fibers of the mentalis. So these are the muscles of the facial expression, and along the inner surface we can make out the mylohyoid line is giving origin to the muscle mylohyoid muscle. So this is also called as diaphragma oris. So it is separating the oral cavity from the chin. So it is forming a diaphragma oris, which is that mylohyoid muscle. Then we have also the origin of the anterior belly of digastric to the digastric fossa. Then here it is the genioglossus and geniohyoid to the genial tubercles. So these are all the muscle attachments. And then one more muscle of the pharynx is the superior constrictor of the pharynx. So behind and below the third molar tooth is the few fibers of this muscle originates, that is superior constrictor of the pharynx. Now next is the nerves related to the mandible. So this is an important question usually asked in the spotters. So what are the nerves related to the mandible now? It is the lingual nerve. So where is the lingual nerve? It is behind the third molar tooth. So this is for the dentist. So whenever for the teeth removal, the anesthesia will be given surrounding this lingual nerve. This is the one which can be felt along the buccal mucosa. So lingual nerve, this is a sensory nerve, then inferior alveolar nerve. So along the within the mandibular foramen, the nerve which enters is the inferior alveolar nerve. Then the continuation from the, that is a branch of this mandibular nerve, will be the mylohyoid nerve, which supplies the same name muscle, that is the mylohyoid muscle. Then mental nerve. So through the mental foramen here, the structure which emerges out and supplies the skin over the chin region is the mental nerve, the terminal branch of the mandibular nerve. Then the nerve to masseter. So masseteric nerve, otherwise called as, so which is present along this notch. So this area is called as the mandibular notch. Between the coronoid process in front and condyloid process behind, there is this notch. So the masseteric nerve emerges from the anterior division of the mandibular nerve and supplies the masseter muscle which is attached along the ramus of the mandible. Then the auriculotemporal nerve. So this is the auriculotemporal nerve. This is the nerve which winds round the neck of the mandible. So this is the sensory nerve and which supplies a secretomotor pathway to the parotid gland. This surrounds the neck of the mandible. This is the question asked usually. Which is the nerve related to the neck of the mandible? It is auriculotemporal nerve. Then marginal mandibular branch or marginal mandibular nerve. So along the lower margin of the mandible, there is this nerve, facial branch, or from the facial nerve, this is the branch given off along the margin of the mandible, hence the name marginal mandibular nerve. Now coming to the one more important question, which is called as the age changes in the mandible. So why do we need to know this is they are different in case of children than in the adult life than in the older age group people. So now let us see what are the differences. Coming to the mental foramen. So the position of the mental foramen as shown in the picture here, in the children or in the child, we can see it is along the lower border, the positioning. Then in the adult it has shifted midway because of the further growth of the mandible, the mental foramen has shifted above. Then in the older age again it has shifted to the upper border because of the resorption of the teeth or the alveolar border. So this needs to be remembered as the nerves are related to these foramen. Then angle of the mandible. So, what are the changes? So, in the children it is 140 degrees, that is the obtuse angle in the children. Then when in the adult life it is reduced to 110 degrees. Then again in the elderly or the old age, the angle has increased to 140. So, usually it is like in the children and in the older age it appears to be the same. So, hence the chin looks more protruded in case of older age. Then relation between the coronoid and the condyloid process. So, if we draw an horizontal line and a dotted or an imaginary line across the horizontal plane, then in the children the coronoid process will be above this margin. Then in adults the condyloid process is above the margin drawn. Then in case of elderly, again the same thing, that is a coronoid process will be above this line. Then coming to the mandibular canal. So, it runs along the lower border in case of children. So, as we know the foramen is shifted downwards, hence the canal also is shifted downwards, mandibular canal. Then in the adult it is again parallel with the mylohyoid line or in the midway. Then in the elderly it runs close to the upper border, as there is shifting of the foramen, the same way even the canal is being shifted. Now coming to the applied aspect or fractures in the mandible. So, usually common areas where the fractures take place will be along the incisive foramen till the lower or the inferior border of the mandible. Whenever there is threshold or heavy weight on this area, on the skull bone, or it has been shifted to the mandible. Then the next area, or usually next area which is involved in the fracture, would be the neck of the mandible, and here the nerve we should keep in mind is the auriculotemporal nerve. So, if the neck has been fractured, then it could be dislocated also from the TM joint, leading to again dislocation of the TM joint. Then usually next at last will be along the angle of the mandible. So, this are the three fractures or the points usually where the fractures take place. It could be one at a time or more than one at a time. Then one more applied aspect would be the dislocation of the TM joint as mentioned. So, which are the commonest ones? TM dislocation, it is usually the inferior dislocation or the anterior dislocation of the TM joint, where the head will be dislocated anteriorly outside of the mandibular fossa, which is belonging to the temporal bone. Coming to the ossification of the mandible. So, the mandible is formed within the membrane or intramembranous ossification. So, majority of the bone is within a membrane, it is completely formed. Then few parts are also endochondral or cartilaginous ossification. The mandible and is the second bone to ossify in the body. So, we know that clavicle is the first bone to ossify in the body, whereas the second bone is the mandible bone. Then part of the mandible between the mental foramen. So, this is the mental foramen and the mandibular foramen will be here. So, between these two, the mental foramen and the mandibular foramen, it is ossified within the membrane, membranous ossification from here to here. That is from the mesenchymal sheath, which is derived of the Meckel's cartilage. So, we know that mandible is part of a skeletal derivative of the first pharyngeal arch or the first arch cartilage, which is called as the Meckel's cartilage. So, mandible is a derivative of this Meckel's cartilage and part of the mandible medial to the mental foramen. So, next is this part medial to the mental foramen. So, here it is directly from the Meckel's cartilage. So, this is the endochondral ossification. We read about the posterior part here, it is membranous, and this one is the endochondral ossification. Then the coronoid and the condyloid process ossify from the secondary cartilages, which is not related to the Meckel's cartilage. So, we need to mention that these processes are secondary cartilages, they are derivatives of, and only the body of the mandible is from the Meckel's cartilage, the first arch cartilage. So, this is a horseshoe shaped bone or the mandible lower jaw. It has got the body and the ramus on the either sides. So, the body has got a superior border, alveolar border for the tooth sockets and the inferior border wherein, so this is called as a symphysis menti in the median plane, and the attachments to this outer surface of the body will be the muscles, that is the depressor anguli oris, depressor labii inferioris, then also the risorius muscle and the mentalis muscle of the facial expression. Then coming to the ramus, so here the ramus is quadrilateral in shape. The anterior border of the ramus continues as an oblique line onto the body of the mandible, and we can see the mental foramen, which is for the mental nerves and the vessels. Then the outer surface of the ramus of the mandible gives insertion for the masseter muscle, where we can see the oblique ridges. Then this ramus has got coronoid process and the condyloid process. The coronoid process gives attachment to the temporalis muscle, then the condyloid process forms the joint, that is the temporomandibular joint, and in between this is the mandibular notch through which the mesenteric nerve will pass through. Then this is the angle of the mandible, so which is formed by the posterior border and the inferior border of the mandible, which is also called as the base of the mandible. Then to the angle of the mandible attachment is the stylomandibular ligament. Coming to the inner surface of the body of the mandible, it shows two tubercles, the superior and inferior genial tubercles, which is for the attachment of genioglossus and geniohyoid muscle. Then below this is the depression, that is the digastric fossa, for the attachment of the anterior belly of digastric muscle. Coming to the inner surface of the ramus of the mandible, so this is the mylohyoid groove, and above this is the mylohyoid line. So, mylohyoid line gives attachment to the mylohyoid muscle, and this groove is for the mylohyoid nerves and the vessels. And we have posterior to this mylohyoid line, so this is for the attachment of the medial pterygoid muscle. Then coming to the inner surface of the ramus of the mandible, so here we can see the tongue like projection, which is called as the linguella. So, behind and below this linguella is the foramen, that is the mandibular foramen. So, this is the mandibular foramen for the inferior alveolar nerve, this mandibular foramen for the inferior alveolar nerve, and the nerve to mylohyoid runs along this groove. Then this linguella gives attachment to the spinomandibular ligament, which is from the first pharyngeal arch. Then we have the pterygoid fovea, which is to the neck of the mandible. So, this is the condyloid process, which has got the head and the neck. So, in the neck there is a depression, which is called as the pterygoid fovea, wherein the lateral pterygoid muscle gets attached. The nerves related will be the lingual nerve related to the third molar tooth here, the lingual nerve. Then to the neck of the mandible, it is the auriculotemporal nerve. Then this is the mesenteric nerve in the notch, mandibular notch, mesenteric nerve. Then inferior alveolar nerve within this mandibular foramen. Then we have the mental nerve in the mental foramen. So, this will be the mental nerve in the mental foramen. So, these are all the nerves related to the mandible. Now, coming to the next bone, that is the cervical vertebrae. These cervical vertebrae are 7 in number. So, out of the 33 vertebrae in the vertebral column, there are total 7 cervical vertebrae, and amongst these there are typical cervical vertebrae which are similar in features, and there are certain atypical vertebrae which has the specific or uniqueness. Now coming to the features of the typical cervical vertebrae. So except for the first, second and the seventh cervical vertebrae, all rest of them all of them will be typical cervical vertebrae. So here the body will be small. So how to identify this? The body will be small and it is broader from side to side. It is broad from side to side than the before backwards, and it has got a superior surface. So when we write it here, so it has got superior surface and below will be the inferior surface. So the superior surface is concave, transversely it is concave. Then projecting lips on either side. So on each sides there are projections from this superior surface. Then the inferior surface, the lateral margins of this inferior surface are beveled. So that is projections are there, it is beveled laterally to form the synovial joint. So what joint does this form? It forms the uncovertebral joints, that is the joint of Luschka, which is formed by the bevel edges of the inferior surface of the body of the cervical vertebrae. Now that vertebral foramen, what about the vertebral foramen? So this is the vertebral foramen. All the vertebral foramens of all the vertebrae, they form the vertebral canal. So we know that within this vertebral canal there is a spinal cord. Now the cervical vertebrae, when we talk about the vertebral foramen here, it is triangular and it is larger than that of the body of the cervical vertebrae. Now why this should be larger? Vertebral foramen here, so through this is the spinal cord, and spinal cord there is a cervical enlargement, so that we have the spinal nerves emerging from this cervical enlargement, which forms the brachial plexus of the upper limb. So there is a connectivity of the brachial plexus to the upper limb, hence the vertebral foramen needs to be larger here. Then the superior and the inferior articular facets. So this will be the superior articular facet. So below will be the inferior articular facet. So these are flat. So we can see that it is flattened superior articular facets here, and it is the superior ones are directed backwards and upwards. So it is backwards and upwards, whereas the inferior facets are directed reciprocally opposite, that is directed forwards. Coming to the transverse process. So we know that any vertebrae on either sides, it is the transverse process which is present. In this typical cervical vertebrae, they are smaller, transverse process are smaller, and it has the foramina called as the foramen transversarium. So this, through this, what is the structure which passes through? It is the third part of the vertebral artery. Then we have the vertebral vein. Also we have the sympathetic plexus surrounding the artery. So these are the structures which passes through this vertebral foramen or the foramen transversarium. Then each of this transverse process has got an anterior root. So we can see here, so this is the foramen, this will be called as the anterior root, and this is called as the posterior root behind the foramen. So it has got the anterior and the posterior roots which ends in tubercle. So this tubercle will be called as anterior tubercle, and this will be called as the posterior tubercles. So they are joined together in between by a bar, so which is called as the costotransverse bar, because it is between the costal element and the transverse element. So this is the costal and this is the transverse element. Between these two there is a bridging, hence called as the costotransverse bar. And the most important point to remember of the cervical vertebrae is the spine is short and bifid spine. So, we can see it is split into two. So, this is a short and bifid spine in the cervical vertebrae. So, two important points is, one is the foramen transversarium in the transverse process, and again the bifid spine are the two important points to remember. This is the typical cervical vertebrae. So, we are seeing a smaller body with the extensions. So, these are the beveled edges of the cervical vertebrae. Transversely it is longer compared to the antero-posterior diameter. Then it has got the articular processes. So, these are the articular facet, superior articular facet, and these are the laminae. So, this is a superior articular facet, and below and anteriorly opposite to that will be the inferior articular facets. Then we have the bifid spine in the cervical vertebrae. So, typical cervical vertebrae will have a bifid spine. Then these are the transverse process. So, in the transverse process we have the anterior tubercle and the posterior tubercle at the ends of the anterior root and the posterior root, and within this is the foramen transversarium. So, which is for the second part of the vertebral artery passes through this foramen transversarium. So, this is the foramen transversarium in the transverse process, which through which the second part of the vertebral artery, the vertebral vein and the sympathetic plexus along with the artery enters through this foramen transversarium. So, these are the typical features. Then the triangular vertebral foramen is larger when compared to the other vertebrae. So, these are the typical features of the cervical vertebrae. Now, coming to the atypical cervical vertebrae. So, which are the unique ones? The first cervical vertebrae, it is otherwise called as the atlas. So, the first cervical vertebrae called as atlas because it supports the globe or that is the skull, nothing but, of the head on its shoulders. Hence, the name given according to the Greek mythology, the god who will be holding the earth. So, it is given the name as the atlas. Then it is a ring shaped, as we can make out here. So, it is ring shape and it has no body, no spine. When compared to the typical cervical vertebrae, this here does not have body or spine, no body, no spine. So, this is a feature of first cervical vertebrae which is ring like, that is atlas. Now, it consists of right and left lateral masses. So, these are the masses or elevations, right and left lateral masses connected by a short anterior arch. So, only this much is the anterior arch, while as a long and curved posterior arch, and it has got transverse processes, that is right and left transverse processes. The anterior arch is marked in the median plane by an oval facet. So, in the anterior aspect there is a tubercle called as the anterior tubercle, and posteriorly there is a facet. So, an oval facet which articulates with the dens. So, within this will be the dens of the second cervical vertebrae. Then this forms a joint which is called as the atlantoaxial joint. So, atlas is the first cervical vertebrae, axis will be the second cervical vertebrae. So, between these two there will be atlantoaxial joint. So, this forms a pivot type of joint for the rotatory movements, that is a no. So, when we rotate our neck to tell it is no, then this joint which is acting is this, the atlantoaxial joint. The posterior arch of the atlas forms 2/5 of the ring, and its posterior aspect is marked by a posterior tubercle in the median plane. So, hence this is the median posterior tubercle. The upper surface of the posterior arch here, so this is the upper surface behind the lateral mass. So, this is the lateral mass, behind the lateral mass is marked by a groove. so which lodges the vertebral artery and the first cervical nerve. So, these are the two important points to remember in a spotter. On the posterior arch of the atlas, what are the two structures? The vertebral artery, that is in the suboccipital triangle, what we mentioned, that is the third part of the vertebral artery. Then the first cervical nerve. So, through the foramen of all the vertebrae, cervical vertebrae, which part of vertebral artery is coming? It is the second part of the vertebral artery, whereas only in the suboccipital triangle along the atlas posterior arch, we find the third part of the vertebral artery. Next is about the lateral mass. So, it has got superior articular facet which forms the atlanto-occipital joint. So, here this is the concave part of the superior articular facet which will articulate with the convex surface of the occipital bone. Hence, the joint will be called as atlanto-occipital joint. So, this is an ellipsoid variety of the joint, and in nodding the head anterior and posterior, that is the S joint. So, ellipsoid variety of the synovial joint. So, flexion and extension alone will be taking place here. The inferior articular facet, so what we are seeing is a superior, below this would be the inferior articular facet which will form the second joint what we mentioned, that is atlanto-axial joint C1 and C2. Then the medial surface, so this is the medial surface of the lateral masses will provide attachment to the transverse ligament of the atlas. So, this is the transverse direction, transverse ligament of the atlas. So, why do we need this? Here anteriorly we have the dens within this. So, this dens has to be fixed in position, which is with the help of this transverse ligament of the atlas. The transverse process of the atlas, it projects laterally on either sides here, and they are stronger and larger than compared to the other cervical vertebrae. So, this is again a feature, special feature to remember. The elongated transverse process will act as an efficient levers for the rotation of the atlas vertebrae. So, this is helping in the rotation because of the wider and or larger lateral masses and the transverse process. So, this is the atypical cervical vertebrae which is ring like, and this is the first cervical vertebrae, that is the atlas. So, it has got an anterior half or the anterior arch of this ring which is smaller, and a posterior arch which is 3/5 of the ring formed. Then it has got the tubercles along the anterior ring. So, this is the anterior tubercle, and posteriorly, so this will be the posterior tubercle, and this is the wider vertebral foramen, and it has got the lateral mass. We can see on either sides the kidney shaped, the lateral mass, wider areas, and this should be concave superiorly. The surface should be concave superiorly. Along the medial surface of these lateral masses, it gives attachment to a transverse ligament of the atlas. Then there is within this transverse ligament of the atlas lies the dens, and here along the posterior surface of the anterior ring. So, this is the articular facet for the odontoid process or the dens of the second cervical vertebrae, that is the axis. So, this cervical vertebrae do not have body or spine, no body, no spine for this. So, spinous process it is absent here, and it has got a transverse process within which there is a foramen transversarium for the again the vertebral artery to pass through this. Next, coming to the second cervical vertebrae, that is called as the axis. It is also called as the ox chyloni. So, that means head of a tortoise. So, it resembles like a head of a tortoise, hence the name given. Atlas will rotate like a wheel around the pivot. So, this is the dens or the atlas part which will rotate surrounding the one more bone, that is the first cervical vertebrae. So, hence this forms a pivot type of the joint. Now, the features are the strong tooth-like process projecting upwards from the body, which is called as the odontoid process or dens. It is one and the same. The odontoid process is representing the body of atlas. To remember, we said that the first cervical vertebrae has no body and no spine. Then where did the body disappear? So, it is here in the second cervical vertebrae. It is represented as the dens or the odontoid process. The dens provides attachment to what are the structures? We need to remember this as a spotter. It is the apical ligament of dens. Then also the alar ligaments. So, the apical ligament of dens and the upper band or the upper cruciate band of the alar ligaments are the attachments to the odontoid process or the dens. So, this would be a spotter question. Then the spine, talking about the spine, it is massive, it is large, thick and very strong and deeply grooved inferiorly. So, below here. Its tip is bifid. So, here the tip is bifid. The spinous process, so it is very massive, it is larger, we can make out that, and it is grooved inferiorly and the tip would be bifid. So, this is about the spinous process. The transverse process, they are very small, we can make out here, they are very small and they do not have the anterior tubercles. The laminae are thick, so this part is the lamina. So, lamina are thick and stronger. The superior articular facet on the upper surface of the body extend onto the pedicles. The massive pedicle will overhang the foramen transversarium. It will cover laterally. The superior articular facets are large, flat and circular, and they are the weight bearing and encroaching onto the sides of the body. So, this is about the superior articular facets. They are large, flat and circular and they are the weight bearing ones. And the inferior articular facet will lie behind the transverse process and it will articulate with the third cervical vertebrae below that. This is the second cervical vertebrae, that is the axis. To identify it, it is the dens and the odontoid process is the feature of identification of the second cervical vertebrae or the axis. This dens gives attachment to the apical ligament of dens and the upper band, cruciate bands of the ligament. Then there is a mass on either sides which is covering the transverse process, and this articulates with the inferior aspect of the atlas bone to form the atlantoaxial type of the joint. So, the transverse process is very small and which has got the foramen transversarium within it. Then the vertebral foramen here, it is wider and the spinous process is very thick, stout for the attachments of the muscles of back of neck. So, the first cervical vertebrae will articulate with the second cervical vertebrae in this manner. So, we have the body is absent in the first cervical vertebrae, whereas the body of the first is present as the dens or the odontoid process of the second cervical vertebrae. So, this is forming the atlantoaxial joint, which is a pivot type of joint. So, here will be the transverse ligament across to hold the dens or the odontoid process in position, and along this the lateral mass there is a groove, deep groove which forms attachment to the posterior atlanto-occipital membrane, as well as it is related to the vertebral artery, and the first cervical nerve or the suboccipital nerve is lying over this groove. Then next atypical cervical vertebrae is the seventh cervical vertebra. It is otherwise called as the vertebra prominens. That means the spinous process of this is prominent, hence called as the vertebra prominens. This spinous process of C7 is the one which is a bony landmark. We can feel it along the posterior surface of our neck, hence called as the vertebra prominens. So, this C7 we start counting the spinous process downwards. So, it is spine is thick, long and horizontal. As we can make out, it is spinous process is long and horizontal and it is not bifid. So, this is again an important point to remember. It is not bifid and it ends in a tubercle. So, tubercle of spine. The transverse processes are longer, they are large and they lack the anterior tubercles. They do not have the anterior tubercles and they are larger. So, this is about the transverse process of the 7th cervical vertebrae. Then the foramen transversarium within the transverse process here. So, it does not transmit the vertebral artery. Then it transmits only the vertebral vein. So, we have to remember that it transmits only the vertebral vein. So, this is about the C7. Then we have to know that the first part of the vertebral artery is present within the scaleno-vertebral triangle. Then it enters directly into foramen transversarium of C6 vertebrae instead of C7. So, from there C6 it is going up to the suboccipital triangle. So, the C7 here it transmits the accessory vertebral vein alone. This is another atypical cervical vertebrae, that is the C7 cervical vertebrae called as a vertebrae prominens, and this is the spinous process which is thick and horizontally placed. So, the vertebral foramen it is becoming very small when like compared to the thoracic vertebrae. It is similar to that of the thoracic vertebrae. Now, coming to the applied aspects of these cervical vertebrae. Carotid tubercle. So, what is this? This is the anterior tubercle which is present along the transverse process of C6 vertebrae, 6th cervical vertebrae. It is larger and hence prominent and hence called as the carotid tubercle. And it is compressing the common carotid arteries in few persons. If it is larger the tubercle, then it can compress the common carotid artery which is present in front of it, hence leading to the syncopal attacks. So, whenever there is complete flexion of the neck in these people, there will be compression of the common carotid artery leading to unconsciousness. So, for a brief time. So, that is called as syncopal attacks. One more important aspect to remember is the hangman's fracture. So, in the hanging condition, so this happens in the axis vertebrae, there will be a break or a fracture usually in the pedicles of the axis vertebrae leading to an enlarged vertebral foramen. The spinal cord will not be compressed usually in this case, but later when the rope glides or slides on, it will lead to the fracture of the odontoid process or the dens, which will compress the vital centers in the medulla or in the spinal cord, leading to the deactivation of these centers. The next important applied aspect again are the Luschka's joints. So, these are the commonest sites of the osteophytes formation. So, these are the smaller bony spicules within the synovial cavity. Then Klippel-Feil syndrome. So, it is a clinical condition in which the cervical vertebrae are fused and deformed congenitally. So, leading to difficulty in the cervical movement. Then the occipitalization of atlas, this is also one more feature or the clinical aspect wherein there is congenital fusion of the atlas vertebrae to the occipit bone or to the base of the occipital bone, hence called as occipitalization of the atlas vertebrae. So, the patient will come with the pain in the neck region or the upper limb could be severed off, the blood supply would be decreased in these conditions, leading to numbness or the weakness of the muscles of the upper limb. So, these are all the applied aspect related to the cervical vertebrae. to summarize, we need to remember that the atypical cervical vertebrae are the atlas, the first cervical vertebrae, then the axis, the second cervical vertebrae, and the C7 or the vertebra prominens. These are all the atypical cervical vertebrae, and the typical features of the typical cervical vertebrae would be the foramen transversarium, which is for the vertebral artery, and we have the vertebral foramen triangular in shape, and the body is very small, and the spinous process is bifid. So, these are the key points to remember from this topic. Thank you.